Hello, I'm Paulo Espada, and I'd like to discuss with you the results of the Thales trial recently published in the New England Journal of Medicine and the American Heart Association Scientific Meeting 2020. Ticagrelor plus aspirin reduces 30-day recurrent stroke death versus aspirin alone. This combination, ticagrelor plus aspirin, lowered the risk for stroke or death within 30 days compared with placebo in patients with acute ischemic stroke or transient ischemic stroke who did not undergo intravenous or endovascular thrombolysis. Both groups had a similar incidence of disability. Although there was an increased risk for bleeding, the absolute risk was small compared with the benefit in reducing strokes. In this randomized trial, researchers analyzed data from more than 11,000 patients aged at least 40 years with mild to moderate acute non-cardioembolic ischemic stroke or TIA without thrombolysis or thrombectomy. Within 24 hours of symptoms onset, patients were assigned to ticagrelor plus aspirin with a mean age of 65 years. 38% of them were women, or matching placebo plus aspirin, both of which were given for 30 days. Patients assigned combination therapy received loading doses of ticagrelor, as in coronary heart disease, 180 milligrams, then 90 milligrams twice per day, and aspirin as a loading dose, 300 to 325 milligrams on the first day, then a maintenance dose of 75 or 100 milligrams daily. The primary outcome was a composite of stroke or death at 30 days. Secondary outcomes included first subsequent ischemic stroke and disability within 30 days. And a primary safety outcome was defined as severe bleeding. The stroke or death occurred in 5.5% of patients assigned ticagrelor plus aspirin, compared with 6.6% of those assigned aspirin alone, with a hazard ratio of 0.83. Ischemic stroke occurred in 5% of patients in the ticagrelor plus aspirin versus 6.3% of those in the aspirin alone group, with a hazard ratio of 0.779, and the incidence of disability was not significantly different in patients assigned ticagrelor plus aspirin compared with those assigned aspirin alone. Severe bleeding was observed in 0.5% of patients assigned ticagrelor plus aspirin versus 0.1% of those assigned aspirin alone, with a p-value of 0.001. So we have now another proven treatment to reduce stroke risk in these high-risk patients, as the researchers said. And the perspective is that the previous studies, including the POINT study and the CHANCE study, showed that the short course of clopidogrel plus aspirin were superior to aspirin alone in preventing major vascular events, mainly stroke in patients with acute, minor stroke or transient ischemic stroke. Clopidogrel is a prodrug that requires hepatic conversion to activation and an estimated 25 to 30% of white people and 50% to 60% of Asian people have genetic variants that affect conversion to this active agent. So ticagrelor is similar to clopidogrel but does not require metabolic activation. And despite differences in patient population, endpoints, and treatment regimens, the results are similar to those of POINT and CHANCE, supporting the benefits that the short course of dual antiplatelet therapy reduces major vascular events during the high-risk period after ischemic stroke or TIA. This comes at the cost of a small but significant increase in bleeding complications. There was no effect of the combination of ticagrelor and aspirin in reducing disability compared with aspirin alone. So these findings support a short course of dual antiplatelet therapy. Comparisons between clopidogrel plus aspirin versus ticagrelor plus aspirin versus aspirin alone are only indirect. A direct head-to-head comparison would be helpful to determine whether one combination offers benefits compared with the other. And there's another trial ongoing that it's been done in China. This is the CHANCE 2 trial that is comparing aspirin plus clopidogrel versus ticagrelor plus aspirin, and maybe the results can share some light on this topic. Thank you.